this webinar on postnatal care during COVID-19 pandemic. Motherhood is a joyous event for women and her family. Besides antepartum and intrapartum care, the postpartum period is very important and should be dealt with utmost care. In this webinar, we will discuss about the general principles of postnatal care, care of suspected and confirmed mother, care and testing of newborn, breastfeeding and breastfeeding options, discharge policy, care at home, and postnatal visit. Before we go on, I would like to reiterate that even during this COVID pandemic, every woman has right for respectful maternity care, which is an essential part of postnatal care and promotes best practices such as rooming in. Women and her family should be fully informed about all the aspects of care, answer their questions, and address their concerns. The aim of postnatal care is to support the mother during breastfeeding and infant care, educate her about her health, nutrition, and supplementation, provide her psychological support. Prevention, early diagnosis, and treatment of postpartum complication is very important. Provide her counseling regarding exclusive breastfeeding and birth spacing method and immunization of the infant. Wherever the delivery takes place, every woman has right for postnatal care, whether she delivers at hospital, clinic, or home. If it is a hospital delivery, postnatal care is provided for at least 24 hours after birth. If it is a home delivery, provide postnatal care as early as possible within 24 hours. According to WHO, at least 3 additional postnatal contacts should be given to the patient at day 3, day 7 to 14, and 6 weeks. The important component of postnatal care is physical well-being, emotional well-being, infant feeding and well-being, and health promotion including nutrition and family planning advice. During the first 24 hours after birth, a regular assessment is done in terms of temperature, heart rate, blood pressure, note for vaginal bleeding and uterine tone, ensure that the patient voids urine within 6 hours of delivery. Beyond 24 hours, inquire about her general well-being, assess for urinary and bowel function, wound healing, perineal pain and hygiene, breast pain, and lochia. At each postnatal visit, breastfeeding should be assessed. At 10 to 14 days after birth, assess about the emotional status of the patient and look for signs and symptoms of any postpartum depression. Counseling is an important part of postnatal care. Inform the patient about physiological process of recovery so that she does not get worried with the minor ailments that are common in postpartum period. Counsel her about nutrition, hygiene, and about birth spacing method and family planning. Encourage her for early mobilization and gentle exercise. These are the general principles of a postnatal mother who is COVID positive or COVID negative. Now coming to the postnatal care in a confirmed or suspected COVID mother, important component is isolation, careful maternal and fetal evaluation, breastfeeding and breastfeeding options either in separation or co-location, the discharge policy, and advice on discharge at home. Once the patient delivers, she is shifted back to the isolation room and requires continued medical evaluation for her respiratory status and symptoms. Provide her standard practices of routine postnatal care. Encourage her to maintain hygiene related to puerial and hand hygiene. Encourage her to take healthy diet to improve her immunity. Contact precaution and use of PPE should be maintained during the postpartum period. If a patient is asymptomatic, routine postpartum maternal monitoring is required. If she has mild symptoms, monitor her vitals every 4 hours for 24 hours if it is a vaginal delivery, every 4 hours for 48 hours if she has undergone a cesarean delivery. If mother has moderate symptoms, SpO2 monitoring is required for 24 hours until improvement occurs. If mother is critically ill, close monitoring is required till the resolution of the symptoms. Now coming to the care of the newborn, it is important that the newborn who has born to a COVID positive mother should be isolated from other healthy infants. Caring should be taken according to the infection control precaution, and testing of the newborn should be done for COVID-19 infection. So if the newborn is a preterm or symptomatic or mother has severe symptoms, requires to be transferred to NICU or isolation after proper contact precautions. But if there are no such symptoms, Then the care of the infant should be discussed based on the maternal symptoms and involvement of mother, family, and the pediatrician. If separation is chosen, then the baby is transferred for isolation. If isolation facility is not available or they choose rooming in, then contact precautions are to be maintained like hand hygiene, mother to wear mask, and baby should be at least 6 feet away from mother's bed if not breastfeeding. And monitoring is required for these infants. Whether rooming in is chosen or a separation, in both conditions, the feeding option should be discussed with the mother and the family based upon maternal symptoms and involvement of the pediatrician. The breastfeeding options include express breast milk or direct breastfeeding and formula feed. However, it should be avoided if other options are there. But if breastfeeding is chosen or exclusive breastfeeding is chosen, then all the contact precautions are to be followed and hand hygiene is to be practiced. If mother's COVID result is positive, then the infant care should be revisited. Testing of infant is required. If the baby is negative, then maintain the contact precaution from mother for 14 days. If baby is positive, close monitoring is required and maintain the contact precaution. But if the mother's COVID result is negative, then routine postpartum and neonatal care is provided and there should be limited number of visitors. Now, important thing during testing a newborn is whom and when to test. So all the newborns born to the mother with COVID-19 infection and symptomatic newborns should be tested. If the newborn is symptomatic, collect the sample as soon as possible. If asymptomatic and roomed in with COVID positive mother, test should be done as soon as possible within 24 hours. And if the first test is negative, then repeat the test after 48 hours. If the facility of testing is not available, treat the infant as positive with clinical monitoring for 14 days observation period and mother has to maintain precaution until non-infectivity criteria are met. WHO recommends co-location or rooming in of well mother and well baby. Close contact, early exclusive breastfeeding helps a baby to thrive. So a woman with COVID positive should be supported to breastfeed safely, hold her newborn and for skin to skin contact and share a room. But the benefits and risks of rooming in and skin to skin contact should be discussed with the mother and with the involvement of neonatologists to individualize newborn care. Support vigilant risk minimization strategies. The main risk is close contact of the newborn with COVID positive mother who is likely to share infective airborne droplets. So the precautions are to be followed, like baby is to be kept at a distance of 6 feet from mother except at the time of breastfeeding. Mother has to follow all the contact precautions. She should avoid coughing and sneezing while breastfeeding. Venous thromboembolism prophylaxis should be considered in COVID positive mother. However, this consideration should be based on individual risk. Breastfeeding is not contraindicated according to ACOG and WHO, and it is the best source of nutrition and general immunity for infant, and all the contact precautions should be followed by mother or the caregiver. Till date, no evidence is there that COVID-19 virus is transmitted via breast milk. If a mother is COVID positive and is asymptomatic or displays few symptoms, rooming in and direct breastfeeding should be considered. If mother has cough, fever, dyspnea, or newborn needs ICU care, the mother and infant needs to be separated and baby should be given express breast milk. The separation is determined on case-to-case basis and the decision should involve mother and the clinical team. The separation depends on the disease severity of the mother, the test results of mother and baby, the parental preferences, psychological well-being, the facility of isolation if possible, and ability to maintain separation even after discharge. If separation is indicated but cannot be implemented, then other precautions are to be taken, such as physical barrier. So a curtain can be put between the mother and the baby and keep the newborn at least 6 feet away from the mother. If mother is breastfeeding or not breastfeeding, she should put a face mask and practice hand hygiene before handling or feeding the newborn. There should be limited number of visitors and all the care providers should don appropriate PPE and follow hygiene precautions. If the mother is unwell, consider sending the baby for home isolation. In separation, the feeding options should be given to the women, like in form of expressed breast milk, wet nursing, or donor human milk. However, the mother should be encouraged to express breast milk, which will help in establishing and maintaining the milk supply. She should be encouraged to practice hand hygiene, and the parts of breast pump should be thoroughly washed and disinfected. The expressed milk should be fed to the newborn by a healthy caregiver. The health providers should also follow proper precaution measures and use of appropriate PPE. They should enable the mother and infant to remain together to practice skin-to-skin contact and rooming in throughout the day and night. They should not promote breast milk substitutes, and postnatal care should be individualized in accordance with women and newborn needs. Routine immunization is to be followed for all the healthy neonates, but if the neonate has suspicion or proven infection, vaccination can be delayed but should be completed before discharge from the hospital as per the hospital policy. Recently, the Ministry of Health and Family Welfare has revised the discharge policy for mother. So if a mother is confirmed COVID-19 positive with very mild or mild symptoms, she can be discharged after 10 days of the symptom onset and if there is no fever for 3 days. If she has moderate symptoms and fever has resolved within 3 days and oxygen saturation is maintained without support, discharge after 10 days of onset of the symptoms with absence of fever without the need of antipyretics, there is no breathlessness and no oxygen requirement. But if the symptoms are not resolved and there is a demand of oxygen therapy, discharge only after resolution of clinical symptoms and she is able to maintain oxygen saturation for consecutive 3 days. In the mother with mild or moderate symptoms, there is no need to repeat the RT-PCR test before discharge. However, if the mother has severe symptoms, discharge only after clinical recovery and negative RT-PCR test once the symptoms has resolved. The stable neonates who are roomed in with their mother can be discharged along with the mother. If rooming in is not possible and mother is sick, then the baby can be discharged after 24 to 48 hours for home isolation and to be cared by a trained family member. At discharge, clear instructions should be given to the mother to isolate at home and monitor their health for next 7 days, and to practice careful hand hygiene and infection control measures when they are handling or feeding the baby. The family members should be educated about the identification of signs of illness in newborn and bursting symptoms in mother and to contact the health facility. Postnatal visits is an important component of postnatal care. To reduce the risk of inadvertent exposure, there is a need to modify or reduce postpartum outpatient care, which can be given either in form of face-to-face contact in the health facility or by home visits, or remote contact, that is through telecommunication or video chat. The face-to-face visiting is prioritized in women with known psychosocial vulnerabilities, complicated or operative birth, premature or low birth weight baby, and if the mother has other medical comorbidities or there are neonatal complexities which require a health facility visit. This is a postnatal contact schedule if remote contact is available. So from birth to 24 hours, a face-to-face contact should be made. At day 3, a remote contact can be made. At 7 to 14 days, a face-to-face contact, and at 6 weeks, a remote contact can be made. But during all these contacts, the ongoing risk assessment should be done and look for any infective risk. However, these modalities may be swapped if the mother needs a face-to-face contact. At each postnatal contact, assess for symptoms of COVID-19 infection. If there are any symptoms or suspicion, inform mandatory self-isolation and advise telephonic contact or rescheduling of the visit. Assess for maternal and neonatal complications and assess for ongoing risk including emotional well-being and personal safety. There should be adequate documentation to ensure appropriate care planning. When a remote contact is being made, it is very important that you first introduce yourself, greet the woman in friendly manner, inquire her about her general health and well-being, emotional well-being, baby's health and well-being. Discuss about the postnatal complications like any form of excessive bleeding, any signs of infection or fever, newborn danger signs, whether the baby is feeding well, having fever or convulsions, and discuss about the family planning methods. Offer her time to ask questions and answer them patiently. Provide individualized health counseling. Discuss about the plan of emergency transport if required. Plan for next postnatal contact and document the assessment discussions and plan. Regardless of where and how the postnatal contact is made, respectful maternity care should be provided. Treat all women with dignity and respect and maintain confidentiality. So, to summarize, respectful maternity care must be at the forefront of the care provided. Postnatal care should be individualized in accordance with mother and newborn need. Breastfeeding is not contraindicated. However, proper respiratory and hand hygiene to be followed by mother and the caregivers. Strengthen the postnatal care for mother through face-to-face contact or through remote postnatal contact, especially for low-risk babies and the mother. Thank you.
Good afternoon, all. I welcome all the viewers to this question and answer session. We have Dr. Anu Thukral with us. She is Associate Professor in Neonatology in AIIMS, New Delhi. And we have Dr. Jyoti Meena and Dr. Vidushi Kulsheshwar. Both of them are Associate Professors in the Department of Obstetrics and Gynecology in AIIMS, New Delhi. So the first question is for Dr. Vidushi. Ma'am, there's a question. It says, should my baby be separated from me if I am COVID positive?
No, it's not mandatory at all to separate and isolate the baby if the mother is COVID positive. Uh, and WHO in fact recommends rooming in as as early as possible. However, some mothers may be apprehensive about rooming in, so we have to counsel them very nicely that it does not increase the risk of transmission to the baby as long as hand hygiene, respiratory hygiene measures are taken care of. So, if the baby is kept in her room, then the baby's cot should be kept at least 2 meters away, and except when she is breastfeeding.
Okay, thank you, ma'am. Next question to Dr. Jyoti Meena. Can I breastfeed my baby if I am COVID-19 positive?
If the mother is COVID positive and if she displays few symptoms or is asymptomatic, then breastfeeding can be considered. In fact, she should be encouraged to do breastfeeding. It will enhance the milk production and initiation also, and it will help in bonding with the mother and the baby. But however, if the maternal condition does not permit or the baby is symptomatic or is needs ICU care, then the separation decision is to be taken after careful counseling of the mother family with involvement of the pediatricians.
Thank you, ma'am. My next question is to Dr. Anu Thukral. Ma'am, this question says, can I give formula feed to my baby if I don't want to breastfeed as I am COVID-19 positive?
So, one thing before I say, similarly, for babies who are not COVID 19 or not born to COVID 19 positive mothers, the standard policy remains the same. So, when I say it remains the same, it means that whether I am or I am not COVID 19 positive, I would continue breastfeeding my baby unless and until there is a condition that the mother is so sick that she cannot directly breastfeeding. So formula feeding is a big no. Continue direct breastfeeding for all babies, even if the mother is COVID-19 positive.
Okay, thank you, ma'am. Thank you. Next question to Dr. Vidushi. Is the virus transmitted through breast milk?
Uh, the literature that is available so far, it does not indicate any viral transmission in the breast milk, and all the samples taken from the breast milk, they were negative for COVID virus. However, the mother has to be careful because it's not the breastfeeding, but it's the nearness to the baby while breastfeeding that may lead to transmission. So, if the mother is wearing a mask, if she is washing her hands and before taking the baby for breastfeeding, or if suppose she has cuffed just prior to breastfeeding and cuffed on her chest, then she has to clean her breast also, but not mandatory for before every breastfeeding. And till now, there is no evidence that breast milk has virus.
Okay, thank you, ma'am. Next question to Dr. Jyoti Meena. When will I be discharged after delivery if I'm COVID-19 positive?
So if the mother is COVID-19 positive, recently the Ministry of Health and Family Welfare has revised their discharge policy. So if the mother has mild symptoms, she can be discharged after 10 days of the onset of the symptoms or COVID test positive. And if she has no fever, then if she has a moderate symptoms, then if the symptoms has been resolved, she has no fever, no requirement of antibiotics, there is no shortness of breath, and no oxygen requirement, she can be discharged after 10 days. But if mother has severe symptoms, then definitely after clinical recovery, and RT-PCR test should be done in cases of severe symptoms before discharge. And after discharge, the patient has to home isolate for at least 7 days and should take proper precautions. Now, I would like to introduce Dr. Ranjan. She is assistant professor in our department, AIIMS, Obstetrics and Gynecology. Dr. Ranjan, I would like to ask you what is the criteria for home isolation? Like, if we send the patient the- at the time of discharge, advising her for home isolation, what should be the criteria?
Ma'am, first of all, the patient should be having no symptoms or she should be mildly symptomatic. At home, she should have facilities for isolation, like there should be a separate room with separate bathroom facilities, and there should be a caregiver for her who can be around to check for her symptoms. And we can also contact her telephonically to ask her about her symptoms, whether there is any new symptom or like if she's doing all right. So most important is that there should be space and caregiver with her to provide home isolation.
So suppose a patient that, says that no, I won't be able to pursue home isolation at my place after getting discharged from the hospital facility, then
in that case, we will have to keep the patient admitted for another 7 days. Like if we plan to discharge the patient on 10th day, if there is no facility for home isolation, then the patient has to be kept for another 7 days. And after that, we can discharge her without RT-PCR testing if she is all right. Uh, okay, ma'am. My next question is to Anu, ma'am. Will my baby be tested if I am COVID-19 positive?
So the latest guidelines actually tell us that immediately after birth at the first opportunity. So maybe the baby is born on a Saturday midnight, then Monday morning becomes the first opportunity. So that is the first time that you do the test. And then another test between day 5 and day 14. That is the latest recommendation. So initially we were doing only once, which is between day 5 and day 14. But now the latest guidelines, they say that immediately after birth, that is one, and day 5 to day 14. Now, immediately after birth is to see the possibility of vertical transmission, and then thereafter to see if the initial one is negative, then just to see what is the status on day 5 to day 14. So these days we are doing this. Now, when I say recommendation, so these are based on the evidence is still coming up. It's weak, I would say. So they are more like expert consensus opinions rather than actual studies to document the rationale for why we are doing these tests.
Okay. Thank you, ma'am. Next question is to Dr. Vidushi. Uh, how should what is the discharge policy in an immunocompromised patient with COVID-19 infection?
As is discussed in cases of asymptomatic patients or patients with mild symptoms or moderate symptoms, we don't need to do a testing before discharge. But in immunocompromised patients, such as a patient having HIV with COVID positive, then we have to repeat QRT-PCR and document a negative test before discharging these patients, just as we do for the severely symptomatic patients.
Okay, ma'am. Thank you, ma'am. Next question to Jyoti, ma'am. How should the postnatal care be followed in a patient with COVID-19 infection?
So once the COVID positive mother has been delivered, now whether she has delivered at hospital or home, if she has delivered at hospital, then we have a policy that we are discharging after 10 days. So the criteria for postnatal visit at day 3 and day 7 to 14 is almost fulfilled. So we can ask the patient to home isolate, and we will do a postnatal visit at around 6 weeks. But if the patient has delivered at home, besides the postnatal care given within 24 hours. The visit should be done at day 3 and days 7 to 14 and then 6 weeks. So these whether to give a face-to-face visit or a remote contact, it should depend on the patient and newborn needs. So at day 3, a remote contact can be done with the patient and ask her about her symptoms, and then the care provider will decide whether the patient will require a face-to-face visit or can solve her problem on telecommunication. So this will prevent her coming from health facility and infecting and getting infected here.
Okay, thank you, ma'am. Next question to Anu, ma'am. What can be the symptoms of COVID-19 infection in a baby, newborn baby?
So the symptoms closely mimic any other bacterial or viral infection in the neonate. So fever, slight irritability, respiratory distress, maybe some loose stools, some vomiting. So you cannot really label that this is because of COVID-19 infection. Majority of the newborns, and that is the point I would like to make, are asymptomatic, or they might have many very mild symptoms which we generally tend to ignore, right? So overall symptomatology generally mild, or newborns are asymptomatic. The disease is never moderate or severe, very rarely so, and the symptoms closely mimic any other bacterial or viral disease in the newborn. So there are no symptoms specific to COVID-19 infection in the newborn.
Okay, thank you, ma'am. Next question is also for you, ma'am. Anu, ma'am. How can I breastfeed my baby if I have undergone cesarean section? Can I have a personal attendant with me?
Okay, so this brings us to the issue of where the delivery has happened. So, if the mother is diagnosed COVID-19 positive, she is in a tertiary care setup. So, the nurse or the attendant, the nurse attendant in full personal protective equipment would help in breastfeeding, and this would continue till the mother is ambulatory. So while we say that mother continues breastfeeding, it is very important for her to wear an N95 mask when she is breastfeeding, and she observes general hand hygiene and is very strict about the hand hygiene and wearing the mask while breastfeeding. So hopefully all should go well, and the mother becomes ambulatory after cesarean typically as early as 24 to 48 hours.
Okay.
Very rarely it may happen that the mother becomes ambulatory by 72 hours. If that is the case, so till that time, the nurse, whoever is helping, should be expert in lactation counseling, and she helps. And the doctors are also around. They would help in breastfeeding the baby, and the nurse would support breastfeeding. And during that time, it is also imperative that some attendant who is COVID-19 negative and voluntarily wants to be with the mother and help her out is trained, so that the same can be done at home. So hand hygiene, surface cleaning, breastfeeding with proper practices is done at home. By 72 hours, mothers are generally ambulatory. You discharge them. Hospital policy is as early as 48 hours. So discharge them as per your hospital policy. But don't forget to train the attendant in basic practices of hand hygiene, general social distancing, wearing the mask even at home, and she can take care of the mother and the baby diet.
Okay, thank you, ma'am. Next question to Dr. Jyoti. Any special precautions while providing postnatal care?
So, while providing postnatal care to a COVID mother, the healthcare provider should don appropriate PPE, that is the level 3 PPE should be done by the healthcare provider. And if the care provider, that is the relative of the patient, if she is providing care to the mother, then she should at least wear the mask and should practice all the hand hygiene and should maintain a distance with the mother. So social distancing should be there. There should be limited number of the visitors, and should disinfect all the surfaces and clean all the utensils which are being used. So proper contact precautions are to be used.
Okay. Thank you, ma'am. Next question to Vidushi, ma'am. What are the protocols for hydroxychloroquine prophylaxis in pregnant women?
This COVID-19 pandemic is with us since December, but with the data so far, it has not been found that pregnancy per se increases the susceptibility to contract the infection or to increase the severity, unlike H1N1. And there are no recommendations to prescribe HCQ for prophylaxis for pregnancy for prevention of this COVID infection, even if they are in the hotspot area. And so, like AIIMS has recommended HCQ prophylaxis only for healthcare personnel, the sanitation workers, and not for pregnancy per se. Close quote.
Okay. Thank you.
Bahulu. Now we have no other question.
We don't have any other questions left now. So I
We
think
will like to
with this, I would like to close the session. Thank you all of you. Thanks all of you.
thank you.